All right. Good morning and good afternoon, good evening to everyone. We're going to get started. I'd like to welcome everyone to session 6 of the Washington Healthcare Facilities Initiative webinar series. My name is Joanne McGriff, and I am the Associate Director of the CGSW at Emory University, as well as Assistant Research Professor in the Department of Global Health at the Rollins School of Public Health. Today, we are excited about our panel of speakers who will be discussing costing issues related to Washington healthcare facilities. I am joined by our members of our learning team, Ms. Lindsay Denny, as well as Cassandra Savino. As you know, this series is part of an action-oriented learning platform that seeks to connect, share, and act. So we connect the expertise and experience of our partners to those in the Washington health community who are interested in moving to action in Washington healthcare facilities. We also provide this platform as well as our website for the community of practice to share experiences, ideas, and best practices. And we also encourage individuals and groups to take specific action to implement sustainable interventions that improve wash conditions in healthcare facilities. So to begin, I invite meeting attendees to start introducing yourselves by placing your name and organization in the chat box as I review just a few more quick notes about the structure of the platform. And also, when you use the chat box, please make sure you select all attendees for your comments, just so that everybody in the room can see who you are and where you are coming from. So, in terms of the actual learning platform itself, our structure is pretty standard. We highlight Washington healthcare facilities subject matter experts in 25-minute presentations, followed by 30 minutes of facilitated discussion. For today, we will have 2 speakers who will present for about 12 to 15 minutes each, and then they'll be followed by a commentator for about 5 minutes. So for reference, please be reminded that you and your colleagues have access to webinar recordings, slides, learning materials, summaries, and action documents through our website, w-in-hcfaction.org. And if you have questions or feedback, you can send us an email at w-in-hcfaction@emory.edu. Remember, we're also on Twitter. And now, just to move things along, I'm going to pass over to Lindsay Denny, who'll provide you with a few additional updates and reminders. After her announcements, I'll introduce our speakers for today and move right into the learning session. Lindsay?
Thank you, Joanne. For those of you who are joining us for the first time, we do like to discuss the guiding principles of this webinar series, which is how we are informed in selecting our speakers and topics. So first, WASH is a fundamental prerequisite for quality care within healthcare facilities. Secondly, we believe there cannot be effective infection prevention and control without adequate WASH in healthcare facilities. Third, sustainability should be built into every Washington healthcare facilities project from the very beginning, no matter the project size. And finally, Washington healthcare facilities is not just about addressing issues at individual facilities. Multiple systems, sectors, and stakeholders must work together to see sustainable improvements. To give a bit of background about why we are here talking about Washington healthcare facilities, Washington healthcare facilities links to 2 of the Sustainable Development Goals, SDG 3, good health and well-being, and SDG 6, clean water and sanitation. In addition, there was a call to action by the UN Secretary General, Antonio Guterres, back in March of 2018. And we'll have an update on that in terms of the resolution. And then we have done 5 webinars in the past, and they've looked at everything from system strengthening, looking at the right assessment tools, the challenges of implementation and opportunities, such as with handwashing and the clean clinics approach. And last month, we looked at research on neonatal sepsis, WASH, and care-seeking behaviors. So if you'd like to see any of those, please head to w-in-hcfaction.org. So as I mentioned, the big news and update for this month is that back at the executive board meeting for the World Health Organization last month, the Washington Healthcare Facilities Resolution was approved by the executive board. It is being officially co-sponsored by 11 countries: Australia, Brazil, Eswatini, Ethiopia, Indonesia, Kenya, Nigeria, Romania, Tanzania, the US, and Zambia. And that means that it'll be transmitted to the World Health Assembly in May, where they will discuss the resolution, and hopefully they'll be passing it by member states. So very exciting and great work by those of you who've been advocating for this. We look forward to the World Health Assembly in May. So that's my only update for this month. It's such a big one. But I do want to give a few notes about Zoom. For those of you who are new to the platform, feel free to use the chat box at any time to introduce yourself, ask questions about the presentation, and then during the interactive discussion section at the end. During the discussion section, you'll have the opportunity to raise your hand to show panelists that you have a question or comment. This way you can verbally give your questions. You don't have the ability to unmute yourself, so we will have to do that for you. That will only happen during the discussion section at the end. If you, then please only use this feature if you have a microphone and can actually speak into it. And I will pass this on to our speakers. Welcome to session 6. We are understanding the cost of WASH in healthcare facilities. Where do we start? And we'll be hearing from 3 speakers. Joanne, would you like to do the introductions?
Great, thank you, Lindsay. So again, we have with us Ms. Darcy Anderson, who is a doctoral fellow in the Department of Environmental Sciences and Engineering at the University of North Carolina, Chapel Hill. Her research focuses on how WASH programs adapt to sociocultural, political, and economic contexts, and how contextual factors influence implementation outcomes. In a previous project, she led a study in Malawi to evaluate the costs of environmental health service provision in healthcare facilities, and she'll talk with us about that. Following Ms. Anderson, we have Dr. Robert Quick, who is a medical epidemiologist in the Waterborne Diseases Prevention Branch at the Centers for Disease Control and Prevention. For the past 28 years, Dr. Quick has worked at CDC conducting research on the etiology, control, and prevention of enteric diseases in the developing world. This work has included a focus on simple, inexpensive interventions to rapidly mitigate the lack of access to safe water for hand washing and drinking faced by a majority of health facilities in the developing world. These quote-unquote quick wins interventions help address WASH deficiencies in the short term while longer infrastructure interventions are being planned and implemented. Both of our speakers will be followed by a commentary by Dr. Deborah A. McFarland, who's an associate professor in the Department of Global Health and the Department of Health Policy and Management at the Rollins School of Public Health of Emory University. Her specialty is in international healthcare financing and health policy. So without further delay, let's get started with Darcy Anderson from University of North Carolina. Darcy?
And Darcy, you can go ahead and share your screen.
Great, thank you, Joanne. Okay, so as Lindsay went through in her introduction, WASH in healthcare facilities is a target under the Sustainable Development Goals and is important to ensuring infectious disease prevention in healthcare settings. But unfortunately, services in many of these areas are lacking. About half of the facilities lack access to basic pipe water, and a third lack access to sanitation, hygiene, infectious waste disposal, and as much as 3/4 of facilities lack sterilization equipment. Now, cost data are critical to ensuring sustainable service delivery, but evidence in this area is really lacking. So we set out on this project with 2 goals. The first was to identify the expenditures necessary to establish, operate, and maintain environmental services. And the second was to evaluate the cost of providing those services. So essentially, what are we paying for and how much money are we paying for it? And we did this through 2 methods. We conducted a scoping review and did framework development, and then we conducted field data collection in Malawi. And through these 2 projects, we developed a 10-step costing process model that's going to be the focus of my presentation today. This model breaks down into 3 steps: an ideation phase, which is the planning phase, data collection, and then a synthesis and dissemination phase. First, I'll walk you through the ideation phase, which contains 4 steps: defining costing goals, defining the service to be costed, defining the scope of eligible costs, and then developing a costing plan. So when we think about defining costing goals, there are a number of things to consider. If you look at the 2 goals here on the right of your screen, you'll notice that they're very different in terms of the scope of the cost information needed. If our goal is to identify the necessary expenditures to establish, operate, and maintain, that requires us to collect a much wider range of information than if our goal was just to understand the total operating cost per patient of a rural water supply. The second thing to consider is what level of detail on line item cost is needed. Again, the first goal here, identifying specific expenditures, requires a much higher level of detail and may be more useful for detailed planning and budgeting within a facility than the second goal, which is just to identify total operating costs. Both are appropriate under different situations, but you need to think about how much information you really need to meet your costing goals and then select one appropriately. Second, what are the unit costs needed to contextualize findings? If you're working just within a single facility, your unit costs are going to be very different than if you're working across a network of facilities and you need to generalize those findings to other settings. And finally, how will cost information be applied? What are the policy goals for doing this costing and selecting a goal that meets those needs? The second step of this phase is to define the service to be costed. This breaks down into two steps. The first is to identify what service will be costed. When we think about wash and HCFS, those needs actually go beyond just water, sanitation, and hygiene. We use the term environmental health services to think about the broader range of services that are needed. So water, sanitation, and hygiene, as well as healthcare, waste management, protective equipment, cleaning and sterilization, laundry, lighting, and vector control. There are a number of things that may be relevant in certain situations, things like building design, heating, or food hygiene, but these aren't things that we focused on for this model because they're not applicable to all facilities, especially the ones that we looked at in Malawi. The second step is to document how each service is provided. This is often something that's done qualitatively, thinking about where is the service provided? Is it provided in just one facility, or is it perhaps a centralized network that occurs throughout multiple facilities? By whom is the service provided? You're going to have service provided at the point of care by nurses and doctors, but there's going to be a wider range of staff involved, such as maintenance workers, cleaners, logistics officers, and administrators. And then finally thinking about what resources are needed, what things are you physically putting into the system and getting out of it. The third step is to define the scope of eligible costs. And a useful thing to think about for thinking about scope is the concept of life cycle costs. Life cycle costs are the idea that you start with installation of a technology or a service that requires purchase of equipment or construction or upgrades to a facility as a one-time investment. And once that installation has been made, you move into operation and maintenance costs, which are routine, regular operation of the service plus associated repairs and rehabilitation. And once the service reaches the end of its useful lifespan, then it moves into decommissioning and disposal, where the technology needs to be removed, safely disposed of, and then a new step is initiated where you move back into installation and you cycle through this process, all of which occurs in this broader environment of supervisory costs. Monitoring and management of the service is essential to each of these steps and is often a cost that gets omitted because it's not easy to observe. And we thought about costs using these categories here on the right. Trainings and personnel are going to apply to every step of this process, whereas building and construction costs are going to be more relevant to installation. And then equipment maintenance, consumable products are going to happen in all of these phases of the life cycle, as well as management and support, which occurs in this broader supervisory environment. Again, being sure that you're thinking about those invisible costs, things like insurance, licensing, and management, that are difficult to observe, but still contribute meaningfully to overall costs. The last step in this phase is developing a costing plan, and there's several sub-steps to this. The first is to identify a data collection and analysis approach. Two useful ways to think about this are in terms of top-down versus bottom-up costing. When we think of top-down costing, you may see it referred to as gross costing approaches, and this is done through looking at a total budget and allocating it to specific facilities based on weighting criteria. So, for example, you may have a district budget for water service provision, and you may allocate that to specific facilities based on weighting criteria such as number of patients, seen per month or per year, or liters of water used if that's actually something you can directly measure. Whereas bottom-up costing is a much more detailed approach, which requires documentation of the individual resource inputs and prices that are then multiplied together to calculate total cost. Things to consider when selecting one of these methods are the level of detail required. Bottom-up costing requires a much higher level of detail, and in return gives you a much richer level of information. Thinking about decentralization of spending, top-down costing is going to be difficult if you don't have good information about total budgets that are centrally spent so that you can allocate them appropriately. And then finally, availability of records and data is an important thing to consider. The next step in developing a costing plan is to select a costing framework or to develop one. We recommend this for two reasons. The first is that a framework provides structure so that you can collect data in a more organized way. And the second is that a good framework will help you identify expected expenses before you begin costing to help you more easily identify and fill gaps in the data that you're able to collect. A good framework will be flexible so that you can it can be applied across different modes of service provision. So for example, if you're costing water supply, a good framework you would be able to apply to costing a borehole versus costing a piped water supply. And finally, your framework should be collaboratively reviewed and adapted with your facility stakeholders. Costing can be a very participatory process, and so everyone needs to understand how the framework works and feel comfortable using it. And adaptation may be needed so that that happens. The last step in the developing a plan process is identifying and potentially adapting and developing data collection tools. Unfortunately, existing tools for data collection have limited applicability and are designed primarily for either wash in non-healthcare facility settings or non-wash in healthcare facilities, things like just routine patient care that don't have an environmental focus. So we encourage you to, if you select tools from one of these non-wash or non-HCF settings, to really heavily pilot, revise, and iterate through those costing tools, and then disseminate them more broadly to the sector so that we can increase the number of tools available. Things that you may think about using are structured surveys or interview guides. Structured observations or code books can be useful if you're doing retrospective records review. The next phase of this process is data collection and synthesis, and I'm actually going to deal with two parts of these together because they form an iterative cycle. This is the process that we used in Malawi when we collected data. We started with a qualitative service provision assessment, as described in step 2, to understand how service is being provided and what resources are needed. We spoke with administrators to identify data sources for those resources that we were expecting, collected data from those sources, and then compared it to our costing framework to see what expenses we had expected versus the ones we had collected. And we identified gaps in that data coverage, and then went back to administrators to identify data sources to fill those gaps, and iterated through this process until we had identified all of the data that we were looking for or determined that it wasn't available. A little bit more detail on each of these steps: identifying data sources, identifying the departments responsible for purchasing is an important first step, and then identifying any record systems that they may be using. Assessing the feasibility of the costing method that you've selected, and does it match with the data that you have available? If you've decided that you want to do retrospective records review, but records aren't kept by the facility that you're costing, you're going to need to reevaluate the method that you want to be using. And finally, you may need to combine data sources across different types, especially in cases where records are not well kept or there's just a general lack of data. Tips for success when actually collecting cost data: again, use a framework. It really helps you structure data collection. Pilot your data collection tools. They may need revision. Triangulate your findings across data sources and really iterate through this process multiple times. Collecting non-cost contextual data is really important for understanding the cost of service provision. And we think about this in two ways. The first is service quantity. And you can think about this as two kind of broad types of indicators. The first is indirect indicators of service quantity, and these are proxy measures, things like patient volume or facility characteristics that don't directly measure service demand, but measure other related things. And the second is direct service indicators, and these are actual direct inputs or outputs to a particular service. So you may think about things like liters of water used, volume of sewage production or treatment, or things like rate of waste generation. The other important set of contextual data to collect is service quality data. If you look at these two pictures here on the right, both are different approaches to water storage, but both are of very different qualities and are going to have very different costs associated with them. So documenting service quality is important to understanding the value of the money that you're spending. There's two ways to do this. The first is through just qualitative description of facility conditions through just narrative text. The second way to do this is through actually using quantitative indicators. You may develop project-specific SMART indicators, so indicators that are specific, measurable, attributable, reliable, and time-bound. You may think about using existing monitoring standards. For example, the JMP has indicators for Washington Healthcare Facility, or you may think about compliance with different national standards that exist within your country. The final step in this synthesis and aggregation phase is to aggregate your data across sources and to evaluate its reliability. So collecting all of the data sources that you've had information for, categorizing them into your cost framework, and then comparing them with your collected versus expected costs, identifying gaps. Where did you expect information that you didn't have it? And then where can you actually go back and find that information? So iterating through and repeating these steps 5 through 7 of identifying data sources, collecting data, and then collecting non-cost data as many times as you need to fill the gaps that you've identified. And when you can't fill those gaps, finally documenting the limitations. The last two steps in the synthesis phase are actually calculating your final costs and then disseminating your findings. When we think about calculating costs, total costs break down roughly into this equation of quantities of resources purchased times the unit cost of those resources. Or if you're thinking about person time, calculating it in the context of salaries of that person times the amount of time that they dedicate to providing a particular service. And when doing these calculations, it's important not to forget hidden costs. Hidden costs may be things like supplies that are donated or perceived to be free, but may not continue to be free in the future and actually have a cost associated with them. Things like financing costs, the loan interest or fees that are paid but are difficult to directly observe, as well as supervision and management costs. All of these contribute to overall costs, but they're not tangible goods, so they're easy to leave out. So I would really encourage you to try to track down these hidden costs and account for them. And finally, to calculate relevant unit costs. Understanding what a outpatient facility with no beds in a rural district has limited applicability. But if we think about costing it in terms of units, so operating costs per year or per service, per liter of water, per kilogram of waste, or per patient or staff member, it becomes much more meaningful to be able to generalize those results and understand how they might apply to different settings. And then finally, did you just lose me? I got an error message.
Yep, we've lost your slides. Could you share again?
Oh no, okay.
Great, we see them.
Are they back? Okay, great. And so finally, this last step is to think about disseminating and applying your results. So these findings may be useful for planning and budgeting internally within a facility, and they may be useful more broadly at the policy level to think about budget allocations and setting national priorities. Finally, to share these findings, there's really a a lack of cost data within these space. So we really encourage you to share findings internally as well as with your external stakeholders, and then disseminate those sector-wide. And I'm going to plug here briefly for people to join our costing project. We're in the process of collaborative review of costing tools, frameworks, and models. We want to help people share data. So if you're interested in participating in collaborative review of these tools, please email us at ehsinhcfcosting@unc.edu, and we'll get you signed up to participate in some of this tools development and review. This is my last slide, final recommendations. The first is to involve staff from a diversity of roles. Healthcare providers versus cleaners versus maintenance workers versus administrators all have useful and valuable perspective to bring to costing. So it's important to gather all those people together to document your costing process that will help you identify, collect, aggregate, assess, and iterate your data to go through this process multiple times so that you can be sure you've filled all the gaps. Triangulating between different data collection sources becomes important to documenting those known gaps and limitations. You're not going to be able to find everything, but documenting what you can't find is valuable. Collecting non-cost contextual data, and then these last two, prospectively documenting lifecycle costs, and then being proactive about good records keeping so that this work becomes easier in the future. With that, I'd like to acknowledge the other people that worked on this project and our project funders, and to leave up our contact information if you'd like to participate in review of these tools. And I'll hand it back to Rob and to Lindsay. So thank you, everyone.
Thank you so much, Darcy. This is just really excellent. And we do thank you for sharing such a comprehensive framework with us. This makes such a valuable contribution as we're all trying to think through all the different elements of costing when going about sustainable interventions in Washington healthcare facilities. So thank you so much. And as you say, we're going to hand it over to Dr. Robert Quick from the Centers for Disease Control. Dr. Quick, if you could share your slides and you can get right started.
Darcy, you'll have to stop sharing yours to be able to let Rob share his.
Okay.
We got it. Great.
Dr. Quick, are you on mute?
I'm about to.
Rob, I think you're on mute.
Okay. Yeah, I'm off mute now.
Great, we can hear you.
Okay, good. Well, thanks for that schematic view of cost analyses, Darcy. It helps me sort of put this in context, which what I'm going to describe as a top-down look at a project we did in Kenya. It was a retrospective look at a project that was responding to a public health issue. This photo just gives you a feel for what we were finding in health facilities in the area where we were working. The water supply for this room is in the small container on the stool there. And so what we were trying to do here was to address poor access to hand washing and drinking water facilities in the short term by installing portable hand washing and drinking water stations. The rationale for this program was the poor healthcare facility wash infrastructure that existed at the time in these health facilities. There was also acute need. There was recurrent flooding that takes place in that area. There had been a series of cholera outbreaks recently, and in fact, that's what led to the targeting of these particular districts. There were also high rates of diarrhea among children under 5 in that area. The other rationale was that these are practical interventions that can be procured locally at low cost and are rapid to implement. The location was in 5 districts in Western Kenya, and there were 117 health facilities in those areas. Our partners were the Safe Water and AIDS Project, a Kenyan NGO, UNICEF, and the Christian Health Association of Kenya. The short-term interventions that we implemented included hand washing stations consisting of buckets with taps, metal stands, wash basin, and a starter supply of soap. And the drinking water stations included a bucket with tap, metal stand, and a starter supply of chlorine or ceramic pot filters, as shown in the lower photo to the right. We did not have sanitation and waste management interventions in this particular project. A program evaluation was conducted of this project several years back in a random sample of 40 of 117 healthcare facilities. The objective of the evaluation was to determine the acceptability and use of these short-term interventions. So to that end, a baseline assessment was conducted in February 2011 that included a survey and observations of water and hygiene in healthcare facilities. In March 2011, the interventions were implemented, and this included health worker training and installation of water stations. The number was based on the patient load in the healthcare facilities. On average, this was about 4 hand washing stations and 2 drinking water stations per health facility. In May of 2012, we conducted a follow-up survey and observations. And this slide shows what we found. The indicators we used included 1 or more hand washing stations with soap or water present in the healthcare facility. At baseline, there were 53%, and at follow-up, 78% of healthcare facilities had these present. So that was an incremental increase of 25%. There were 18% of healthcare facilities with 1 or more improved drinking water stations. That increased to 98% in follow-up, so for an incremental increase of 80%. And finally, 1 or more safe water stations, which were defined as having positive free chlorine residual or a filter, increased from 5% of healthcare facilities to 58% at follow-up for an incremental increase of 53%. So our cost analysis was done retrospectively several years later. We wanted to estimate the cost of the short-term interventions for all 117 healthcare facilities in the program and to determine the average cost per beneficiary. The beneficiaries include health workers, households, and individuals. For health workers, we extrapolated the total from 40 evaluation healthcare facilities to all 117. For households, we used catchment area population estimates from the Kenya Master Health Facility list to estimate the number of households. And for healthcare facilities without catchment area data, we used evaluation data to estimate the number of households as a function of average number of patients seen daily. And finally, for individuals, we multiplied the number of households in the catchment area by the median number of persons per household as determined by the evaluation. The basis of our cost analysis were incremental changes in access to hand washing and drinking water stations in healthcare facilities. So the incremental change just involves subtracting baseline from follow-up percentages of healthcare facilities with hand washing stations with water and soap, improved drinking water stations, that is a bucket with a tap and a lid or a filter, and safe drinking water stations, which were improved water stations with detectable free chlorine residual or a filter. These I showed you in the previous table, these incremental changes. The assumption we made was that incremental changes in the 40 randomly selected healthcare facilities were similar across all 117 facilities. Our cost analysis looked at broad categories of training, equipment, supplies, and distribution, and indirect. I should add that we had the entire budget from the project to work from, and more detailed information is in the paper we published on this particular evaluation. We calculated the cost per beneficiary by multiplying total program costs by incremental increases and dividing by the number of healthcare facilities, health workers, households, and individuals. So program costs are as shown in this table. Overall, the program cost $44,651. And when we look at program cost per beneficiary, we see in this table that there were 117 healthcare facilities, 822 health workers, 214,000 and some households, and over 1 million individuals. So when you look at hand washing stations with soap and an incremental increase from baseline to follow-up of 25%, the cost per healthcare facility was $1,527. Per health worker was $217. Per household was 83 cents, and per individual 17 cents. For improved drinking water stations, which had an incremental increase of 80%, the costs were $477 per healthcare facility, 68 per health worker, 26 cents per household, and 5 cents per individual. And finally, for safe drinking water stations, which had an incremental increase of 53%, the amounts were $720 per healthcare facility, $103 per health worker, 39 cents per household, and 8 cents per individual. We did not consider recurring costs in the analysis. These included commodities such as chlorine solution, soap, and replacement of hand washing and drinking water station components, which were 10% of the initial cost. I should say in the original program, these were covered for a 3-month period. And the assumption was that it would be picked up by the health facility or the district health offices after that. We estimated the average commodity cost per healthcare facility per year to be about $155. We also did not consider filling and cleaning the water stations as part of the cost analysis. Again, based on health facilities having assigned these functions to existing staff. There are several limitations to this analysis. We had a relatively short follow-up period, so we couldn't assess sustained use. The findings are not generalizable because of limited number of districts. The outcome of one or more water station that we accepted for analysis is a very modest achievement, and we've since changed how we look at this, and I'll get into that in a moment. Direct costs also may have increased over time, so the cost is going to be an ever-changing piece of this. We also did not examine long-term costs for infrastructure. However, we were curious, and we checked around with partners who did infrastructure there, and we came up with a conservative estimate of about $15,000 to $40,000 per healthcare facility, not including hospitals. And using the assumptions from the analysis, we found that the cost, if these costs were true, the cost per health worker would be about $2,100 to $5,700. Cost per household about $8 to $22 per household, and the cost per individual about $164 to $437. In the future, our cost analyses are going to look a lot different, reflecting the evolution of this program. There are costs of stakeholder engagement, which has become a big part of the projects we're doing on an ongoing basis. Also, establishing systems to support sustained use and maintenance of wash interventions will be factored in. We have also changed our coverage indicators for hand washing stations to include all patient care areas, laboratories, and pharmacies, and coverage indicators for drinking water, which would include inpatient wards, outpatient areas where oral medicines are administered, and waiting areas. We would also include coverage indicators for healthcare waste separation in all areas where waste is generated. We would consider waste disposal, also the cost for cleaning staff. And then since long-term infrastructure is factoring into our current projects, we will look at those costs as well and get more accurate ideas on that cost. So I would like to acknowledge my colleagues who I worked with on this particular project, and I'd like to thank you for your attention.
Thank you so much, Dr. Quick. Great practical example of doing a costing exercise within a program. In the interest of time, I'm going to move quickly to Dr. Deborah McFarland from Emory University's School of Public Health, both the Department of Global Health and Department of Health Policy Management. Dr. McFarland, if you can unmute and please give your commentary.
Thank you, Joanne, and thank you to Darcy and to Rob for your excellent presentations. Because we do not have a great deal of time, or I don't have a great deal of time because I've got to run off to class, which I realize is a poor excuse, but nonetheless, there it is. I'm going to just give a couple of comments on each of the presentations and then go to some more general comments. So in some of them may seem very specific and may be more ones that I can pass on to the presenters in feedback and to those who want to do costing. On the UNC presentations, Darcy, thank you very much for the schematic. I think it's critical to have that for anybody who is doing costing of anything. So I appreciate the fact that your group has put together that costing framework. I'm also very happy that you are collecting or conducting an inventory of cost instruments. There are cost instruments. Every public health intervention has costed its activities and its inputs. And I want to come back to that in a moment. The cost, I found a couple of things in the slides which I was a bit confused about, and perhaps you can discuss those in the discussion period afterwards. I think there's something of a confusion about activities and inputs. So let me just step back a moment and say one of the things that for costing any intervention or for costing any program is to differentiate between what are the key activities and what are the inputs required for those activities, and then who's going to pay for those particular inputs. One of the pieces that I wanted to come back to in general comments was I know that this session was on understanding the cost, but we've got to think about cost as one piece of the puzzle and revenue as the other piece of the puzzle. Again, I'll come back to that. So the activities, laying out activities. Sometimes training, for example, is considered an activity and you have it as an input. I think we have to be very, this is what we have to navigate with our collaborators and what we have to navigate with those who are using the cost data. Training is actually an activity that uses a lot of inputs. Inputs may be personnel, inputs may be supplies, inputs may be venues. So let's be clear about activities and inputs that are required in order to conduct those activities over time. You mentioned in one slide, Darcy, and I honestly can't remember which one it was, you had something that said you're going to conduct a cost effectiveness analysis stroke cost benefit analysis. And I suspect that many on this webinar are clear about the difference between cost effectiveness and cost benefit analysis. But I would encourage you to make sure you differentiate that cost effectiveness and cost benefit analysis are quite different animals and require, in the denominator, very different analysis. And then the last thing, and Darcy and those at UNC, again, I appreciate the detail and the logic of the cost flow, the cost framework. One thing for your last slide that you might want to consider is whose job is it to document costs? If you go to a facility, cost information can sometimes be quite controversial. It can be quite sensitive. Whose job is it? Who holds the purse strings? Whose job is it to document costs? And is it the accountants? Is it the administrators? Are they accessible? But identify who or what office conducts and documents costs that you want to do. And then the other questions that I have, I'll come back to in a more general comment. For Rob, thank you again for this empirical analysis, and I do appreciate all the work that you've done on costing over the years. It's great. None of us can practice medicine without a license, but everyone can practice economics without a license, and Rob's a great example, and I appreciate his interest in this topic and the fact that you've done costing for many years. I do have a question about the outcome, and that is the cost per health worker. I'm not sure why that's relevant and how you have incorporated that into your decision making. Just a question. Another question that may be in the paper that you wrote and published. Did you convert costs to a base year? And again, to Darcy and to those of you online, when we look at costs, if this study was done in 2011, 2010, 2011, 2012, were the costs measured at that particular point in time, or did you go to those facilities now and collect costs? And which cost year did you use? We need to be very clear about which cost year we are using. The average cost for healthcare for commodities, $155. I would encourage all of us to put this in context. What percent of the healthcare facility budget is this? If the healthcare facility has a budget of $1,000, then $155 is a significant proportion of the hospital budget. And I would encourage us to put that in perspective, because you at the end said something about you're assuming that the facility is going to pick up these recurrent costs or these costs per facility for commodities. And that may just be a strain on the budget of the healthcare facility. All right, let me come to general comments, and I'll do that in about 5 different categories. One, and perhaps you've talked about this, Joanne and others, in other of your webinar sessions, but anytime we talk about costing and expenditures at either facility or programmatic or individual level, we have to put that in the context these days of universal health coverage. Universal health coverage, as many of you will know, has 2 major components, and that is identifying an essential package, and Washington healthcare facilities may be part of that. I'm not sure. Every country is navigating and negotiating its own set of essential packages, and to what proportion of the population those services or interventions are going to be extended. And the second component of universal health coverage is that there would be minimal, that we want to provide financial risk protection for households. All ministries of health and ministries of finance are living within the context not only of SDGs, but also universal health coverage, which is a priority for Dr. Tedros at WHO. So anytime we're thinking about these, whether we're teaching about it, whether we're putting it in our instruments, I would encourage you to put it in that context. And then more specific comments. In the framework that both Darcy, that you laid out, and Rob, that you used before you had the framework, I would I didn't see anything that said, whose costs are we looking at here? Whose costs? What perspective are we taking? We're taking the health facility perspective. We're taking the donor perspective. We're taking the household perspective. Whose costs? What's the time frame? Is this over a 1-year period, a 5-year period, a 3-month period? Always be sure that you include that. Darcy, you mentioned, and I really appreciated you including this in the framework, and that's the question of, in terms of data collection, is the juice worth the squeeze? That is does it cost us more to collect the data at a micro level that we need than the value of that, or the importance of that cost in terms of being a cost driver? And that's another component that I would hope that you would all think about adding in your cost. And that is, at the end, in terms of your analysis, what are the cost drivers? Are those cost drivers personnel, supplies, etc.? Then I mentioned that costs is just one piece of a financial analysis, and that is that total costs and total revenue go together. So where does the revenue come from? Is it programmatic revenue? Is it donor revenue? Is it government revenue? Is it household revenue? Is it user fee revenue? Because you've got to find some way to cover the costs, regardless of how minimal those costs might be or how high those costs might be. So that's another perspective that I would encourage you to think about. When we think about costs, we want to think about, as I said, a costing base year, but also any price changes that have occurred in the purchase of commodities. Suppliers, whether as we extend and scale up these interventions, that there may be economies of scale and that you can navigate and negotiate price discounts with your suppliers. I want you to always include that as well. And just to reiterate again, that cost data can be quite sensitive, and many, both donors as well as governments may be quite reluctant to give you budget data. Budget data is easier to get, but we don't want to use budget data, we want to use expenditure data. So let's make the distinction between trying always to get expenditure data, not budget data, because the difference between budgets and expenditures may be quite significant. So with that, I think I'll stop because I know I've gone up my 5 minutes, and I appreciate the opportunity to participate. Thank you so much for asking me. And I'm really proud of you guys for moving this very important topic ahead in the context of WASH in healthcare facilities. Thanks very, very much.
And thank you, Dr. McFarland. Really, really excellent points for us to consider with what our presenters have shared. Again, so much to think about. And so now I know we have a few minutes for questions, and I know we have our attendees here. If you have questions, remember in this discussion portion, we ask you to either place your questions in the chat box or raise your hand. And if you do raise your hand, please leave it raised so that we can see you and make sure to call on you. And then remember that we are the only ones that can unmute you. So please don't look for mute buttons, but just raise your hand and we will turn you on and allow you to speak. Remember, if we don't get to your questions today in the chat box or we don't get to your hand, we will continue accepting questions later on, and we'll work with Dr. Quick and Dr. McFarland as well as Ms. Anderson from UNC to respond to as many questions as possible later on our website. Again, so much information to chew on and think about. Please, if you will, let me know if you have any questions. Okay, so we have one question here. So for Darcy, Ms. Anderson, if you could talk with us about the issue of good records. You mentioned in your presentations that it's important to have good records in order to proceed with a cost analysis. If the records are missing, what aspects of the framework is amendable and still usable? And can we do a proper analysis with gaps in our records?
The framework that we designed is meant to be applicable in situations where records aren't kept. And some of the ways to address lack of records are things like observations to, as Dr. McFarland was talking about, to assess the activities that are happening in a facility and to document the resources that are being put in. And then you may think about turning to other alternative sources of data, such as calling suppliers to figure out the prices of those items, or speaking to other facilities that may be providing comparable services, and to recovering data in other ways. And that's why the planning phase of the framework that we've developed is really important to assess what data sources are available, and then to perhaps iterate back to earlier stages of planning to realign your data collection plan with the data that are actually available. So oftentimes, yes, it's easier when records are available, but I think the model that we've designed largely applies, even in instances where records are not being kept.
Okay, thank you, Darcy. Another question we have for Dr. Based on this analysis, is your recommendation that one should begin with short-term interventions for hand washing and drinking water? Why or why not?
Yeah, thanks, Joanne. What I would say is our group at CDC is currently involved in a project where the goal is to get complete wash coverage in healthcare facilities over a period of several years. And so ultimately, we're trying to get to SDG 6 in these healthcare facilities. However, often when you do your assessments of healthcare facilities, you find deficiencies. Few or no hand washing stations, for example, or inadequate waste separation, waste bins to separate waste. So given that, we believe that it's important to take care of immediate needs in a low-cost way if you can. That puts something in place that alleviates some of the problem while you continue to work on the longer-term prospect of putting in infrastructure, which requires financing and contracting and putting things in place. So I'm not saying I'd make a blanket recommendation that this should happen everywhere, but we have found that it's useful. And I should add that CDC is often in the position of responding to outbreaks of different diseases in developing countries, and sometimes we see these acute needs and we want to address them on the spot. So that's where this perspective arose from.
Great, thank you, Dr. Quick. Just really quickly, for either Ms. Anderson or Dr. Quick, would you like to make any comments or response to some of the commentary points that Dr. McFarland raised?
I'll respond to a couple of her very good comments. Deb is always has such good perspectives on things and incisive comments. She asked me in particular, what about the cost per health worker? How is it relevant? And our belief is that health workers need wash infrastructure to protect themselves as much as they need it to protect patients. And so we believe it's relevant in that sense. So you're just getting an idea of what the cost per each type of beneficiary is. She asked also, did we convert costs to a base year? And we really didn't, because this was a one-off project and we had the total costs at our disposal to do this analysis. So we were really, our costs were for that base year, and we didn't really project forward. And she also asked about cost putting the cost of commodities in context, and that is an excellent point. Healthcare facility budgets are often low. We were making the assumption that soap is an essential part of healthcare provision. However, we do find in our projects that often soap is not present everywhere it should be, and that's largely because of budget problems. In the future, we're going to be working a lot more with health systems to try to ensure that these particular commodities form part of the budget, or at least they're better prospects for these being procured and used. So I'll stop there.
Great, thank you. I just want to give a few seconds. Darcy, did you want to comment or?
Yeah, if I may add to what Rob has said, some of Deb's comments, they're all spot on, and many of them are reflected in what we've been finding in our systematic review of the literature, and that a lot of these things she's saying are really important to cost or to report on, things like time frame and developing, a standardized reporting system for time and for year of cost are really not done in the literature. So I would just like to second that point, that if you're going about costing, as someone who's looking back on these data, having been collected years ago, it becomes really difficult to apply them if those things aren't done. And then to address her point about contextualizing some of these findings within essential packages of healthcare or thinking about universal health coverage, that is lack of clarity and lack of definitions as to where WASH falls within those concepts, I think is contributing to the lack of development of kind of rigorous and standardized costing procedures. And that is something that we at UNC within the Water Institute are working towards developing better definitions for, that we hope can add clarity to advance this space in a more useful way.
Great. Thank you so much to both of our speakers, Darcy Anderson from University of North Carolina, Chapel Hill, and Dr. Robert Quick from the Centers for Disease Control, as well as our commentator, Dr. Deborah McFarland from Emory University's School of Public Health. In the interest of time, we're now going to close the webinar. We do know that there are some chat questions that we did not get to address, but please be assured that we will work with Dr. Quick and Ms. Anderson and Dr. McFarland to respond to those and put them up on our website, w&hcfaction.org. And as we mentioned, there was just so much shared today that you'll probably want to review this video. And so it will go up, and I'm going to turn it over to Cassandra Savino to wrap up for us.
Thank you so much for joining us, everyone. And thank you so much again to Dr. Rob Quick, Darcy Anderson, and Dr. Deb McFarland. The research you shared with us is so important to help us in understanding the cost of WASH in HCF. Please remember, even though the webinar is closing, you can continue submitting questions in the chat box. We will collect them and send them to the presenters and post them on the Action website, along with supplementary materials such as a summary and recommendations for action. Our next webinar will be held on Wednesday, March 13th at 9 a.m., and we will be discussing cleaners with presenters from the Soapbox Collaborative. Please be aware that there is a time change in the US and not in the UK at that time. Thank you again for your participation, and we hope to see you at our next session.
Thank you all. We'll keep it open for a few minutes. Please feel free to put in notes, and we will see you next month.
Thanks, everyone.